Hi everyone, so this is surprisingly my second last video to go over with everyone. Sorry about the glare on the glasses. I don't know about you, but all this screen time has been giving me serious headaches, so I ended up getting blue light blocking glasses, which thus far I can definitely recommend them, although the glare really sucks, especially if you're like me and you're not used to wearing glasses. But anyway, so just general housekeeping and reminders. You have your second healthcare change journal coming up on the 7th of August. And keep in mind that, again, you do need to do a post-change behavior frequency rating, whatever, like same thing as your baseline one, but after the change. So keep in mind that that has to occur over a week. So given the time that this video shall be posted, you need to have started that. So if you want to be able to have 7 days worth of your health behavior, don't leave this till the last minute. You won't do nearly as good of a job. Ask questions if you need them. This is much more of a researchy paper than a reflective paper, especially for part 2. So a few questions that I have gotten that I will make a FAQ post on Blackboard specifically for this one. Although the FAQs from the first Healthy Change Journal, many of them probably do still apply, so check in there too. Some people have asked about the date for the 2 scholarly journals, like if there's a date requirement. And generally, the newer the better. I'll always stand by that. Usually, we're encouraged to at least try and stay within the last decade. If you're like me, I still consider anything in the 2000s to almost be just yesterday, even though if it's like 2001, that was almost 20 years ago. So just keep in mind it's pretty easy to accidentally pick older ones. That said, I have no date requirements, so just for good practice, I encourage you to choose sooner ones if you can find them, but especially considering we're talking about some theories that were established a while ago, it's possible that you'll find older ones. So for the purpose of this assignment, I don't have any requirements there. I've gotten a lot of questions about the first part, so like reflecting on how it's gone, and to oversimplify it, but basically asking like, do I write in past tense or present tense? Like, am I just copying from my first journal? So keep in mind that obviously you may not have completely changed the health behavior by now. So yeah, absolutely, you may still want to continue, but keep in mind that the second journal is supposed to be reflecting on how the past 6, 7, however many weeks have gone. So it's been like 2 months since you handed in your first journal by the time the deadline comes up. So by that point, you in theory have been trying to make this behavior change for like 2 months. So yeah, you may want to be continuing, but the purpose is reflecting on the past 2 months. So yes, some of the questions, like the first part of part 1, where you basically just reintroduce and reiterate what the behavior was, yeah, it's going to be very similar to the first journal, but no, it shouldn't be exactly the same, because instead of telling the reader, hey, this is what I picked, you're now reflecting of like, this is what I chose 2 months ago, and this is how it went. So keep in mind that this is a reflective process. I mean, you totally can add aspects in there of like, I want to continue this for sure, but the purpose is to reflect on how the past 2 months have gone. And that said, when it comes to using the appendices that you used for Journal 1, like I said, if it's easier for you just to see if there's any difference, like maybe if you put in maybe if you redid factors that hinder and help, looking back now, because hindsight's 2020, you see things better on the back end than you did in the beginning. You might come up with more things that got in the way, or maybe things that you thought were going to get in the way didn't. So don't hand those in. I don't need to see them. But just the idea is to reflect back on what you said back then about what you thought was going to hinder and help, all the other ones like prefactual thoughts that you thought might get in the way, motivations, things like that. Reflect back on those and, see, like, just kind of think about that. Did they get in the way? Were you as motivated as you thought you were? Were you less? Were you more? Did those prefactual thoughts actually get in the way? Things like that. So just like kind of use the same stimulating things that you had in those appendices, try and reflect back on them now and see if they still played a role. So anyway, be sure to ask questions, because of me or the GAs that are marking them right. It's better to ask questions now than it is to say you didn't know when maybe you misinterpreted something or misunderstood something and you're not happy with an aspect of your grade. It always sucks to be on the back end saying like you could have asked. Especially with this being an online course, I'm finding you don't get nearly as many emails as you do, like even when I wasn't the instructor, but when I'm a GA for intro psych, because I mean, maybe not this upcoming year, but when it's been in-person courses, I get a lot more emails. I know it's a lot more students, and they're usually first-year students, so obviously they need a lot more guidance then. But you know, I'm not getting that many questions, and I just don't want you guys to be on the back end thinking that, oh, I didn't understand that, but you totally could have asked. So feel free to shoot me emails, but do check out the video that I posted specifically about this assignment, and keep an eye on the Blackboard FAQ areas or any announcements that I have. So anyway, in my last video, when I do chapter 15, I'll chat a bit about the final exam and what the plan will be for that. Probably won't be much interesting information, but just again to reiterate it, an overview and whatnot. But otherwise, keep an eye also on the deadlines for the quizzes. I'm going off memory here, but I know most of them have been due on Fridays, but that wasn't an exclusive rule. And I think 15 isn't due on the Friday. I think there's one more that isn't due on the Friday. It's due midweek, just because of the requirements for when I can have things due, etc. Because I know when chapter 7 quiz came up, it wasn't due on a Friday like all the other ones have been, and I got a few emails from people wondering where it was when the Friday came around, because they had missed it. So just be sure to keep an eye on the deadlines, because I mean, it's only worth 1%, but still, it's kind of a piss off to realize you missed something like that, right? Especially if you intended to do it. So anyway, moving on, chapter 14 is all about psychoneuroimmunology and immune-related disorders. So these are less of disorders of lifestyle and more when your immune system goes wild, pretty much. So again, in case you missed it in my previous videos, I'll reiterate here, I'm focusing more on the aspects of this chapter that weren't covered in previous chapters. So, you know, we've spent a lot of time talking about stress and depression and personality factors and how those things play a role. And there are things that were probably like unique, like how it uniquely impacts these illnesses. But a lot of the times the factors are pretty similar. Same thing with like CBT interventions, mindfulness, relaxation, etc. So be sure to read these parts of the chapter and ask questions if you don't understand it, because you can still get tested on it. But it's a pretty dense chapter, so I want to spend the bulk of my lecture talking about things that are less covered. So anyway, this chapter is all about the immune-related disorders and psychoneuroimmunology, which is basically a big word for the interactions of behavioral, neuroendocrine, and immunological processes of adaptation. So just a brief overview again, reminder of what the immune system is, because we haven't talked about that since chapter 2, I think, way in the beginning. Essentially, the job of the immune system is to kind of distinguish what's you and what's not you. So what's the body and what belongs there, and what's foreign and doesn't belong. When it's determined to be foreign, it's then attacked to remove it from the body, like intruder alert, let's get rid of it. So remember, there's two forms of immunity, natural immunity and specific immunity. Natural immunity is a generalized defense against pathogens, so it doesn't go for just one thing. So you may get some natural immunities from breast milk, or when you're in utero, like you'd get the person's immunities. Specific immunity response is a response to only one invader. So it's designed to be specific for a specific foreign pathogen or virus or whatever. So this is like the specific virus from immunizations. Natural and specific immunity work together to conquer pathogens in the body and keep you healthy. So kind of whatever the general immunity can't get, the specific immunity can kind of hop in and take over. So to assess immune functioning, research-wise and everything, we have a lot of different approaches we can use. So first, we can assess the functioning of the immune cells. So if they're working well, then your immune system should be functioning. If they're not, then obviously it doesn't. We can examine the activation, proliferation, transformation, and cytotoxicity of the cells. So for example, you may assess the ability of lymphocytes to kill invading cells. If they're overactive or underactive, then that's kind of an indicator that the immune system isn't working as it should be. Second, you can assess the production of antibodies to latent viruses. All of us carry around inactive viruses. When you get chickenpox and you overcome it, that virus is still in you, it's just inactive. So if your body starts producing antibodies to these inactive viruses, so starts trying to fight something that isn't active or doing anything in the first place, that kind of suggests that the immune system isn't working well, because the body shouldn't be trying to fight something that isn't doing anything. Third, we can assess levels of immune system products, so products of the immune system, such as pro-inflammatory cytokines. Cytokine levels are indicative of inflammatory activity and may increase response to stress. And lastly, we can look at indirect measures, such as how quickly wounds heal. So when your immune system is working well, your wounds should heal in kind of a general window of time, shouldn't take too long. Wounds heal faster when the immune system is functioning well and take a lot longer if the immune system isn't functioning well. So to study this, researchers will sometimes make a small puncture wound in a person's skin and then look at how it heals in different people, such as those under stress versus those who aren't under stress, those who are immunocompromised versus those who aren't, etc. So clearly, stress can impact your immune system, and there are two basic principles to understand the relationship between stress and the immune system. First, different kinds of stressors require different kinds of defenses. So, a particular immune system response may be favored over another for certain stressors. For example, a long-term stressor needs a different immune system response than a short one. Second, maximally efficient immune responses have a cost. So, nothing is without a cost or without a payout. There's a cost for immune system kicking in and working hard to fight whatever the stressor is. The cost may entail, for example, suppressing other aspects of the immune system. Like, I need to pay attention to this stressor coming up right now, so I really can't focus on all this other stuff. So if you think about when your body's dealing with the stress of an upcoming exam, you're more susceptible to getting a cold because it's kind of focusing on the exam stress right now. Because not all immune functions are equal and not all stressors have the same demands, there are different relationships between immune functioning and different forms of stressors. So immediate short-term stressors, like minutes kind of thing, produce a pattern of immune responses. Specifically, these stressors that last for only minutes elicit immune responses that anticipate risk of injury and possible infectious agents. So, we could get hurt right now and are infected. So if you think about a sudden fall off a bike, for example, this is coming from prehistorically when, you might be chased by an animal all of a sudden. Other short-term stressors may include things like sudden fear and nerves, like if you're suddenly called on in class. So these are much more common nowadays than I'm being chased by a tiger or a bear. This process relies heavily on natural immunity because specific immunity takes a while to develop. Brief stressors that are days long, not weeks, years, months, and not seconds, but a few days, like preparing for an upcoming exam, instead rely on humoral immunity, not cellular immunity. So remember that humoral immunity is a fast-acting reaction involving secretion of antibodies into the bloodstream. So this type of immunity is effective at defending against anticipated invasions. So these days-long stressors, you know the exam is coming. So it's getting closer and it's coming, but it hasn't come yet. So humoral immunity is much more effective for this because it's designed for anticipated, expected threats. And lastly, chronically stressful events like weeks, months, even years, are linked to adverse effects on nearly all measures of the immune system, like low level inflammation. So if you think back to general adaptation syndrome, eventually everything just gets exhausted, just gassed from fighting. So these long-term stressors, it's like you fought and then you just kind of run out of energy, but then the stressors are still like beating on you, essentially. So the impacts of stress on the immune system are widespread and can have negative impacts on your health then. So stress is related to increased vulnerability to infectious disease, like colds, flus, and then viruses like chickenpox virus. So if you think about how, like I said, everyone gets sick in exam season, it's like the exam room will be completely quiet except for everyone sniffing, sneezing, blowing their nose. Also, stress predicts more severe illness when it does occur, and higher production of cytokines among people who are already sick. So it may make you more likely to get ill, and if you do anyway, or when you do, you may become more ill than you would have otherwise. So like an annoying little sniffle might turn into a full-fledged cold that's hard to get out of bed. The autoimmune disorders discussed in this chapter are particularly impacted by stress because these illnesses are associated with deficits in the immune system functioning already. So if your immune system's already out of whack and then you get stressed, which further impacts your immune system, that's gonna make a bad situation worse. So if you remember the importance of social support on health, interpersonal relationships are then important for the immune system, and stress impacts this, so everything's related. Lonely people that have few interpersonal relationships and therefore little social support have poorer health and immunocompromise compared to people with more social support. So they're more likely to have a malfunctioning or inadequately functioning immune system and poor health overall. Also, people who have interpersonal relationships but have insecure attachments to others show lower natural killer cell cytotoxicity, which impacts their ability to fight off infections. Further, chronic interpersonal stress, so if you think of maybe an unhealthy relationship with your caregivers or a toxic romantic relationship, this chronic interpersonal stress predicts inflammatory activity over time. So these impacts have been seen as early as adolescence and may underlie that relationship between social stress and disorders like atherosclerosis and depression. Further, if you remember that supportive marital relationships are one of the most protective factors for health, on the flip side, marital disruption and conflict are related to adverse changes in the immune system functioning. So separated or divorced women, for example, show poorer immune functioning than married women. Recent separation and continued attachment or preoccupation with the ex were associated with poor immune functioning and with more depression and loneliness. So not just whether or not you're separated or divorced, but kind of your stance on it. So whether if it was recent and or you're still really attached or clinging to whoever you're separated from. Understandably, an abusive relationship then is related to poor immune functioning. Even short-term conflict can have a negative impact on the immune system. So, prolonged romantic relationship conflict can significantly impact the immune system. These risks appear to be higher for cisgender women than cisgender men. And if you remember the discussion on caregivers and how stressful caregiving can be, intenseful stressful caregiving then is related to adverse effects on the immune system. In one study of caregivers with loved ones diagnosed with Alzheimer's disease, caregivers were more depressed and showed lower life satisfaction than a comparison group of non-caregivers, and they had higher indicators of poor immune functioning than the comparison group. Other studies have shown adverse effects on, again, wound repair and lower natural killer cell function, and on reaction to flu vaccines among caregivers. So moving on to our first autoimmune illness, we have HIV and AIDS. So AIDS' full name is Acquired Immune Deficiency Syndrome and appears to have been started in Central Africa in the early 1970s. Now, the rate of spread was very high because of a high rate of extramarital sex, unsafe sex like lack of condom use, and the high rate of gonorrhea in the heterosexual population. So, a big issue is a lot of people think of protection as protecting from pregnancy specifically. However, that's not the only thing it's protecting from. Condoms are protecting from STDs as well, like HIV. Further, the effort to vaccinate as many people as possible led to the reusing of needles. So you want to get the vaccines out there, but you didn't have enough needles, so you reuse them, which, if it was used on someone who's HIV positive and then you use it on someone who's negative, now that could have transmitted the disease to them. Currently, AIDS is still the 6th leading cause of death worldwide. So even now, there is still quite a high rate of HIV and AIDS in transmission. The viral agent of AIDS is HIV, the human immunodeficiency virus. So HIV attacks the helper T cells and the macrophages of the immune system and is transmitted exclusively by the exchange of cell-containing bodily fluids. So these are most prominently semen and or blood. Following transmission, HIV grows very rapidly in the body in those first few weeks. So early symptoms are pretty mild and non-specific, like swollen glands and mild flu-like symptoms. So those non-specific symptoms that don't really indicate to you that you have HIV, maybe you just feel like you ate something bad, or maybe you just feel like you possibly got strep throat from someone. After about 3 to 6 weeks, growth slows down to a more gradual pace, and the person may actually experience a long asymptomatic period. So if you can imagine your first symptoms being non-specific, like mild flu-like symptoms, and then after a few weeks, now you have no symptoms, that's kind of confirming to you that I just ate something or I had a stomach bug because now I feel fine. It doesn't exactly indicate to you I might have HIV, I should go to the doctor. However, this gradual growth will eventually compromise the immune system by killing those helper T cells, which produces a vulnerability to a host of opportunistic infections, which would lead to the eventual diagnosis of AIDS. So it's essentially breaking down your body's immune system and ability to fight off infections. Some of these more common opportunistic infections are things like pneumonia and more unusual cancers like non-Hodgkin's lymphoma. Additionally, people with HIV at this point may begin to show abnormalities in their neuroendocrine and their cardiovascular responses to stress. So in addition to things like diarrhea and skeletal pain and even blindness. So now we're starting to see more specific symptoms of the illness. Impairments of the central nervous system may occur, resulting in symptoms like forgetfulness, concentration difficulties, psychomotor retardation, decreased alertness, withdrawal, anhedonia, or like loss of interest in activities, and loss of sexual desire. If these sound familiar, it's because they all look a lot like the symptoms of depression. And, truthfully, someone can be depressed, but it may or may not be like depression on its own. It may specifically be like symptoms of the HIV. So it can be very common to get a misdiagnosis of depression at this time because it looks so much like depression, and in reality it is, but it may not be arising as its own diagnosis. It may be secondary to the HIV infection. Thankfully, through the improvements of modern medicine, there's a lot of advances in the treatment of HIV and AIDS, and it is viral, so it's chronic and it's not something that's cured, but these advancements have made what was, certain death sentence into a chronic illness, giving people hope and a longer quality of life. Of these advances, Anti-Retroviral Therapy, or ART, is the primary medical advance, which is a combination of antiretroviral medications. So in some people, HIV can no longer even be detected in the bloodstream. So they're pretty much without HIV. The earlier ARTs initiated, the better. And this is because the virus has had less time to do damage. So imagine that you knew you were maybe at risk, had some risky sexual activity. Maybe you knew that you had unprotected sex with someone who was HIV positive. And imagine you saw a doctor in those first few weeks where it's growing rapidly, but you're having those non-specific symptoms. Imagine if you caught it that early versus, months down the road. Additionally, the treatment is very time and labor intensive, requiring medication to be administered regularly at specific times, sometimes multiple times a day to be effective. So the treatment can require a lot of changes to a person's lifestyle in exchange for a better quality of life and management of the illness. So it can be very worth it, and it's quite intensive and demanding in exchange for this longer life. Now, unfortunately, because of stigma and preconceptions regarding HIV and AIDS, non-disclosure is a huge barrier to controlling the spread of HIV infection, so getting people to admit that they're HIV positive. Further, the people less likely to disclose, unfortunately, are also less likely to use condoms during intercourse, further impacting the spread of the illness. People are more likely to disclose when they have strong social support networks, and therefore are more likely to receive social support in return. If you know you're surrounded by people who won't judge you for being HIV positive and who will support you, you're more likely to tell them that you have HIV in the first place. Additionally, there are positive health consequences of disclosing, including more helper cells in the immune system compared to disclosers. This may be related to the impact of more social support. So, although difficult, disclosing that you're HIV positive can positively impact your immune system and therefore your health. So, due to the implications of HIV, interventions centered around encouraging testing, refraining from risky sex, using a condom, not sharing needles, etc. These interventions are key to halting the spread of HIV. Interventions are most effective when tailored specifically for the demographic groups at most risk. So like adolescents, members of the LGBTQ+ community, low-income women, minorities, women, individuals working in the sex trade. Education plays a huge role in these interventions. So most interventions begin by educating the target audience about risky activity. Protection isn't just to protect against pregnancy, and the consequences of risky activity, and provide information on how HIV is transmitted and how to protect yourself against HIV. Additionally, education is helpful to address the many false beliefs about HIV. So for example, there's still much stigma and belief that HIV is perpetuated by anal sex among gay men. However, if you look at table 14.1 in your textbook, much of the transmission is through heterosexual behavior. Like for me personally, I was always, my limited education on HIV transmission was that it was, quote unquote, a disorder of gay sex. And it wasn't until I was in, even graduate school that I actually learned the true facts and how common it actually is among, heterosexual sex. So this can result in an assumed safety from HIV. If you're heterosexual and you believe you've never been with a partner who's ever had gay sex, so you might assume you're safe and you're immune, for lack of a better word, so then you don't need to protect yourself. Additionally, people are overprotective of themselves around people they know are HIV positive, but underprotective among those they assume but don't know are HIV negative. So if you know someone has HIV, you're more likely to, practice safe sex, not share needles, protect yourself. But if you don't know, you're more likely to just assume that they're HIV negative and therefore less likely to protect yourself. This relates directly to the lack of safe condom use, needle sharing, things like that. Additionally, education is beneficial to help prevent secondary infection for HIV positive individuals, preventing them from spreading it to other people. Overall, culturally sensitive interventions, again, are better because they can be adjusted to align with the lifestyle and beliefs of the target group. So there's no one-size-fits-all approach. Now, obviously, targeting safe sex and sexual activity is a huge area, an important area for HIV prevention and education. But also, obviously, this is a very personal area of someone's life, and knowledge doesn't always translate into behavior. Someone may view spontaneity as part of their sexual identity. It's what they like to do. It's how they like to live. And they can be very defensive if someone suggests that they shouldn't live that way, maybe feeling judged. And they may disagree with these careful precautions encouraged to prevent HIV. Additionally, becoming sexually active is a very intense emotional experience, and obviously has a lot of physical and psychological pleasure associated with it. And these things can inhibit someone's judgment, such as choosing to have sex without a condom because you realize neither of you have one, and it's either don't have sex or, have unsafe sex, or stop, get a condom, etc. And you may not be in the most logical frame of mind in that moment. So sometimes even knowledge doesn't translate into behavior in these instances. So a primary area of sexual activity intervention is practicing sexual negotiation skills. These are very important with high-risk groups like gay men, sex workers, adolescents. These interventions include practicing how to resist the pressure to engage in risky sexual activity, like maybe if neither of you does have a condom and you really don't want to keep going without one, but the other person, so it's fine, it'll be good, don't worry about it. So being able to hold your ground in those instances. Building self-efficacy for, demanding and practicing safe sex. Condom negotiation skills are particularly important for at-risk groups, and motivations targeted among these groups to even motivate them to change their risk-related behavior. So motivating them that it's worth it to demand safe sex and to abide by safe sex. Another prominent area of focus is targeting adherence, so adherence to ART. As stated, adherence to ART is critical and is usually high because of the payout. However, stress can impact adherence, in addition to things like alcohol use, things that inhibit your judgment. Additionally, people may have difficulty getting their ART medication, especially the cost, especially in places that don't have universal health care. I can't imagine the cost of ART meds, or they may have issues adapting their lifestyle to accommodate medication. Because of financial constraints, access to affordable health care, adherence is poor among low SES, like homeless people, and among IV drug users, those who abuse alcohol. In addition to financial constraints, there's also a lot of practical issues that you may not think of. So for example, ART medication needs to be refrigerated. And someone in poverty, someone who's homeless, may not have access to a refrigerator to refrigerate their medication. So it's not just getting the medication, but the requirements involved in storing it and administering it, etc., that may not be feasible for a lot of people. Other contributing factors to adherence are things like psychosocial factors, like low social support, higher levels of depression, and low self-efficacy. So these have come up a lot in previous chapters. So adherence to ART is improved using a lot of similar adherence improvement strategies, like motivational training, interventions to enhance social support and improve self-efficacy. Everyday things like text messages to remind people to take their medication have all been related to increased adherence. Next, targeting intravenous IV drug use is another major area in HIV prevention. So don't share needles. Don't dispose of needles on the ground, because if someone who's HIV positive uses a needle, maybe leaves it lying out, and then someone steps on it, and now it's been inadvertently transmitted into them. Interventions with IV drug users need to be targeted towards both reducing contact with infected needles and changing sexual activity, because these drugs may impair judgment, making risky sex more likely. Injection practices may be improved by providing information about AIDS transmission. It's not just from unsafe sex, it can be from needles as well. And the involvement of needles in that transmission, in addition to informing people about safe injection sites, needle exchange programs nearby, and instructions on how to sterilize needles on your own if you don't have access to a safe injection site. The combination of methadone maintenance treatments and HIV education, specifically that combination, is really helpful to reduce the spread of AIDS because of the reduction in shared needle contacts, reduction in risky sex behaviors, reduction in the number of sexual partners, and reduction in unsafe disposal of needles. So understandably, HIV may be really difficult to cope with, both due to the illness itself and the preconceptions related to the illness. So the implication of psychosocial factors can therefore impact the course of HIV infection. Negative beliefs about oneself in the future, depression, stress, trauma, all these things increase the disease progression. Additionally, psychological inhibition may promote a rapid course of illness, such as inhibiting key aspects of your personality, like inhibiting your sexual identity. Psychological inhibition is related to alterations in the sympathetic nervous system and in the immune system, which may account for these effects. Like, you can imagine the stress involved in hiding your sexual identity. That can definitely impact the stress response, like the sympathetic nervous system. On the opposite end, positive affect, like optimism, appear to decrease the disease progression, and an active coping strategy, in addition to conscientiousness, extroversion, and spirituality, are helpful at slowing disease progression. Spirituality may be because of a connection with a spiritual other, and also because when people have spiritual beliefs, they're more likely to have some sort of congregation or spiritual group, which can increase social support. Excuse me. Moving on, cancer. Obviously that's an umbrella term for over 100 different forms of cancer, and while they have a lot of differences, they all share several factors. Namely, all forms of cancer result from a dysfunction in DNA, in the part that controls cell growth and cell reproduction. So instead of the cells producing slowly, gradually, as needed, they grow rapidly and they proliferate. So these cells provide no benefit to the body. They basically just go gangbusters, replicate, take over, and drain the body of its resources. So they're just taking, they're not giving anything back to the body. Cancer may arise from genetic factors, some more than others, but the risk for many cancers arises from modifiable health behaviors. So if you think about smoking and lung cancer, things like that. So interventions may be used to target these risk factors, improve coping and quality of life among those with cancer. So genetic factors, ethnicity, culture, lifestyle, socioeconomic status, marital status, dietary factors, they're all are associated with cancer and with increased or decreased risk for cancer. Many cancers have genetic factors. However, other factors linked to cancer have genetic and or lifestyle links from your genetic in-group, like your family. Diet, lifestyle, personality, etc., all run in families, both due to the behaviors they model and possibly genetic linkages. So, whether your family's super active or eats healthy, eats together versus, eating out a lot, not moving around a lot. Ethnic heritage increases the risk for certain cancers as well. So, for example, in the United States, Anglo men have a greater chance of developing bladder cancer and a higher rate of malignant melanoma. Ethnicity can be protective as well as being riskier. So there are, again, good things and bad things always. So Latino people, for example, have the lowest rate of lung cancer compared to other ethnicities. Now, obviously, culture and lifestyle is one of the largest risk factors for cancer, particularly because of the impacts culture may have on one person's lifestyle. So for example, Japanese American women are more susceptible to breast cancer the longer they live in the United States and the more they adapt and acculturate to the American culture. So the more they transition from their own birth culture in Japan to American culture and American customs. This can be attributed largely to the changes in diet exercise associated with American culture. So the more they acculturate to American lifestyle, the more sedentary they may become, the larger the portion sizes, the more unhealthy dietary choices, all those lovely things that can be associated with westernized cultures. Additionally, socioeconomic status is related to cancer, and with the risk of cancer rising as socioeconomic status decreases, largely due to the impact on lifestyle, so the inability to afford maybe a gym pass, etc. Now, married people, particularly married cisgender men, have a lower rate of cancer than single people. So this may be due to social support and due to a close partner who may notice subtle changes or symptoms in their spouse that they may not notice on their own. Lastly, dietary factors account for a large amount of risk factors. Cancers are more common among people who are on extreme ends of the dietary spectrum, so malnourished individuals and those who consume high levels of fats, alcohol, and certain food additives. Given the widespread biopsychosocial impact of cancer, psychosocial factors can have a significant impact on cancer's course and cancer's development. Avoidance has been related to a more rapid course of the disease because the individual does not face the cancer and confront it and do something. Again, depression can exacerbate the impact of other risk factors like smoking, alcohol use, poor diet, exercise. Progression of cancer may be related to the use of denial or repressive coping strategies. Like avoidance, denying the cancer and or repressing it inhibits the person's ability to actively cope and face the disease. Indeed, repression is related to having cancer in the first place. Negative expectations about their prognosis, like will they just die, or can they overcome this, fight the cancer and survive cancer, and how they experience cancer is related to more rapid course of cancer and a poorer outcome. And this is true even among young patients who may have less competing factors for death and for deterioration. So if you remember how stress and psychological factors work together to impact the stress systems in short term and the long term, altered functioning of the body's stress response can therefore cause cancer to progress rapidly, especially if it impacts your immune system and your body's ability to fight any illnesses or ailments. Then it's going to reduce your body's ability to fight and work with the cancer. So a diagnosis of cancer rapidly changes a person's life in all aspects and requires significant adjustment regarding the physical ramifications, but also the lifestyle changes and the demands of the treatment. So not even just the cancer, but the treatment that you need to undergo. The entire social circle is impacted too, in addition to the individual. So it's only the individual that, legitimately has the cancer, but, their entire in-group is impacted in some way. Physical difficulties may stem from pain and discomfort of the illness, in addition to discomfort from the treatment. So this is particularly prominent in the advancing stages of the illness. Sleep loss, fatigue, depression are especially common due to the illness. Further, nutrition's often compromised by the cancer and the cancer treatment, which can further perpetuate the physical ramifications because you're not getting the proper nutrients to fuel your body and give it its strength. Now, cancer treatment is often very painful and unpleasant and creates its own issues. I know of a few people that have beaten cancer, undergoing chemotherapy or radiation or whatever, and, are happy to obviously be around, but they said if they ever got it again, the treatment is almost not worth it, depending on your specific circumstances and how these individuals experienced it, right? So in some cases, vital organs may need to be removed and replaced by a prosthetic or a transplant. Individuals with prostate cancer may have compromised sexual functioning, which has a huge impact on your quality of life and maybe your self-concept. Chemotherapy has horrific side effects like nausea, vomiting, weight loss, hair loss, cognitive difficulties. People have reported like a chemo brain, in which they experience a lot of mental cloudiness that can impair their ability to work and function. So now they're more forgetful and they can't concentrate. Fortunately, less volatile forms of chemotherapy are being developed. So hopefully we're reaching better stages of medical treatment that can fight cancer without causing such significant impacts in a person's life. But one thing that is related to a more positive prognosis of having cancer is when people can find meaning in it. So some people report ways that cancer actually made life better for them and helped them grow. So people may report improvements in personal relationships, finding meaning in their life, finding purpose in their life. So it's not like cancer's great, but when people can kind of find a reason for having it, like maybe they realize the things that really matter in life, the big problems. Like I think I've mentioned in another video, my Taylor Swift obsession, which by the way, I highly recommend her surprise album. But she had said, her mom having cancer made her realize what the real problems were. So she focuses on the real problems now, like her mother having cancer, not the little things. So this might be an example of a meaning people find. So these experiences can be helpful for prognosis. Namely, they may help lessen and or mute the neuroendocrine stress response, which can have a beneficial effect on the immune system. So despite the unimaginable difficulty brought about by cancer, if you can find meaning, if you can find purpose of the experience, you may fare better, because the alternative is almost like taking a victim stance, kind of, and just dealing with it without trying to find any positive or any light in it. Now, next up, we have arthritis, which includes rheumatoid arthritis and osteoarthritis. So arthritis is the most prevalent of the autoimmune disorders and is one of the most common causes of disability. Overall, arthritis refers to more than 100 diseases which attack the joints or other connective tissues depending on the form of arthritis. Rheumatoid arthritis, or RA, is the most crippling form of arthritis, primarily occurring in people between 40 or 60 years of age, but it can occur in younger people. It usually affects the small joints of the hands and feet, as well as the wrists, the knees, the ankles, the neck, so the joints. In mild cases, only one or two joints are impacted, but with severe cases, the inflammation may extend to, the major muscles like the heart, the blood vessels, the tissues beneath the skin. So it can move from just being in the joints to the major muscles as well. Rheumatoid arthritis is brought on by an autoimmune process. So agents of the immune system kind of go rogue and attack the thin membranes that surround the joints, which leads to stiffness, inflammation, and pain, because those thin membranes are helping to protect the joints. If left untreated and uncontrolled, the bone and the surrounding muscle tissues of the joint may be destroyed. In individuals with RA, most recover completely with treatment and or can manage without significant symptoms, but about 10% are left severely disabled. The main complications of RA are pain, limitations in activities because of the pain too, and the need to be dependent on others for assistance. Additionally, the older individuals with RA may experience an interaction between the arthritis and other conditions leading to greater disability. Stress has a significant impact on rheumatoid arthritis, both in its development and its course. Of stressors, relationship stressors appear to be a pretty big factor, especially the relationship between a spouse or a partner. So the partner appears to play a significant role in the experience with RA, impacting accurate perceptions of fatigue, pain, and limitations. So, for example, if the partner perpetuates that the person is severely disabled by the disease, they're less likely to be able to function well in day-to-day life. Like, you can't do that. Like, that's gonna flare up your arthritis. You need to be careful. Treatments for RA include aspirin, rest, and exercise. So nothing really, housey for that TV show or groundbreaking or anything, but pain control, rest, and exercise. So exercise was once avoided to prevent aggravation of the illness, but it's critical to engage in, supervised or just like careful exercise to preserve that mobility and that strength. Unfortunately, adherence is often low because, if it's painful, you don't really want to do it, or maybe you just don't have time in your usual life to be taking extra rest or to be exercising regularly. So interventions have been developed to address this. Classic CBT interventions have shown promise, like biofeedback, relaxation training, problem solving, skills training, pain coping training, particularly for the chronic pain associated with arthritis. Additionally, mindfulness interventions have shown promise to help the individual focus, on what they can control versus what they can't, and avoid ruminating on what's past or worrying about the future. Now, in comparison to RA, osteoarthritis is most common among women over the age of 50 and occurs when the smooth lining of a joint, known as articular cartilage, begins to crack or wear away because of overuse, injury, or other causes. Because of this wear and tear, it's most common among heavily used weight-bearing areas like the hips, the knees, the spine. As the cartilage deteriorates, the joint may become inflamed, stiff, and painful. The disease is common among the elderly because of years of wear and tear, but it's also common among athletes who tend to overuse certain areas of their body. So, I can't imagine the knees, the ankles in basketball players or in hockey players too. Although treatable, more serious symptoms may lead to a poorer quality of life. Depression is really common, which in turn can elevate the pain and distress of the illness. So treatment for osteoarthritis is similar to RA and is a lot of self-care. So, keeping the body at a healthy weight, especially because these are weight-bearing joints, you want to have not an unhealthy amount of weight on these joints. Using aspirin, painkillers to control the pain, and rest, regular exercise. So much of this is just a lot of self-care. But like rheumatoid arthritis, people who manage osteoarthritis with active coping efforts instead of passive or avoidant appear to cope better. Now lastly, we have type 1 diabetes. So where type 2 diabetes, if you remember from the previous chapter, is regarded largely as an illness of lifestyle, maybe arising from too little exercise, improper diet, obesity, etc. Type 1 is autoimmune and is characterized by an abrupt onset of symptoms. These symptoms result from a lack of insulin production by the beta cells of the pancreas. This disorder may appear following a viral infection and likely has a genetic contribution. So people with a familial history of type 1 diabetes are at a greater risk of developing it themselves. So if you remember with type 2 diabetes, the pancreas momentarily overproduced insulin, which damaged the cells producing the insulin, decreasing or eliminating their ability to do so. In type 1 diabetes, the immune system is at fault here and falsely identifies the insulin-producing cells in the pancreas as invaders and destroys them. So this compromises and or eliminates their ability to produce insulin. So here it's not from overuse, like crash and burn kind of thing. It's from the body actually attacking itself. So type 1 diabetes usually is most commonly developing in these two age ranges of either 5 to 6 or 10 to 13, although it can come up in other ages and areas. So the most common early symptoms of type 1 diabetes are frequent urination, unusual thirst, so needing to drink a lot, excessive fluid consumption, weight loss, fatigue, weakness, irritability, nausea, uncontrollable cravings for food, especially sweets, and fainting. So if you look at all these symptoms, they're all attributed to the body trying to find sources of energy, so desperately looking for sources of energy, which prompts the body to feed off its own fats and its own proteins. So that's where you're getting your weight loss and your fatigue, definitely making you irritable. The byproducts of these fats then build up in the body because they're being used for energy, which would produce these symptoms. Now, if left untreated, this can even lead to someone to fall into a coma, even death. So then obviously this is a very serious illness and can be very life-threatening, not to mention the threat to the quality of life that can result. It's managed primarily through direct injections of insulin, hence the name insulin-dependent diabetes. So if you've ever seen anyone with an attached insulin pump, someone with type 1 diabetes is at a high risk for hyperglycemia or high blood sugar, which can itself lead to coma and death. Now, carefully monitoring glucose levels is key to controlling the progression of type 1 diabetes. So individuals with this illness need to monitor their glucose levels throughout the day and be prepared to take immediate action when necessary. So if you've seen people with like the built-in skin tags to be able to take their blood sugar very regularly so they don't have to keep pricking their finger. So basically the patient needs to be an active co-manager in the own treatment of their illness. Managing this illness typically includes regular insulin injections, dietary control, weight control, and exercise. Food intake must be relatively constant regarding caloric intake and other nutritional indicators. So a meal plan is necessary and you can't just eat based on what you're feeling at that moment. When properly controlled, the risk for the development of related disorders like eye disease, kidney disease, nerve disorders, these can all be cut in half. So proper controlling can be very effective to preserving health and quality of life. Unfortunately, though, adherence to treatment management is low. Only about 15% of people with type 1 diabetes adhere entirely to treatment recommendations. Keep in mind how difficult adherence is to measure and study, because no one wants to tell the doctor that they're not adhering to their treatment. So people often over-report adherence. One reason for this low adherence is the lack of immediate consequences of non-adherence. So it's not like after one day of not regularly monitoring insulin or eating, bad food for one day is going to result in coma and death. Severe complications usually aren't evident for 15 to 20 years after the onset of the disease. So the person may experience little or no symptoms to deter them from straying from their treatment plan. And the temptation may be a lot to resist. The most common issue of adherence is a failure to self-monitor blood glucose level, and often just try to rely on what it feels like. So instead of monitoring it with blood tests or readings, they may use their mood as an indicator. So if you've ever felt shaky or faint or irritable when your blood sugar is low, they may kind of go off their own known bodily processes and responses to blood sugar, which can be accurate, but is very, subjective and very possibly inaccurate, right? Because I can imagine what a pain in the butt it is to have to take your blood glucose level numerous times throughout the day. People with 1 diabetes do better at adhering or managing their disorder, again, when they use active coping strategies compared to passive or avoidant ones. Adherence is improved further when patients and their physicians share treatment goals. So instead of your physician just kind of talking at you and saying you need to do this is what we have to do here, cooperating together and coming up with a treatment plan to help a person meet their own specific goals. Like maybe they want to be an athlete. Being an athlete with diabetes is very difficult because heightened exercise and what that does with blood sugar, versus if you don't want to be an athlete. So discussing treatment goals and plans with the patient and having a cooperative patient-physician relationship is really helpful for optimizing success and adherence. Now, remember, type 1 diabetes most commonly develops between 5 or 6 or 10 to 13. And remember that when we reach adolescence, we experience a dip in our health behaviors because we're not really paying attention to that, and our caregivers aren't monitoring it as much as we usually are. So there's understandably complications, particularly to adolescents with type 1 diabetes. The restrictions imposed by the illness are often inconsistent with the development. So, restricting alcohol use and the freedom to eat what you want. So if you finally hit 19 or 18 in some provinces and you can't go running out and getting drunk because of your diabetes, that's not really fun for a lot of people that age. Or just being able to go out and eat whatever you want at McDonald's or a pizza party or whatever. It really gets in the way with a kid being a kid. Additionally, the difference of having type 1 diabetes and its treatment can be stigmatized by peers. So unfortunately, the different people are targeted. And I know medical advancements now might be a little more subtle, but when I was a kid and I'd see people with the attached insulin pump, I can imagine that could stand out by unfortunate bullies, right? So the adolescent may avoid treatment to avoid rejection and to fit in with their peer group. And well-meaning parents or caregivers can play a role in this as well. Parents and caregivers may have their loved one's best interests at heart, yet may react in ways that aren't necessarily helpful or effective. So for example, they may treat a newly diagnosed child as fragile and infantize them, decreasing their independence, restricting their activities more than necessary, so almost trying to bubble wrap them. On the flip side, alternatively, they may try and encourage the child that, yes, you have this illness, but you're still normal. It doesn't mean you can't have a normal life, right? And unfortunately, there's nothing wrong with someone that has type 1 diabetes in a self-worth sense of the word. There's nothing wrong with them. They're still a human worthy of happiness and a fulfilling life. And their immune system is not normal. Their system is not normal. They do have an illness and they do have legitimate things to manage. So going too far in saying they are perfectly normal might discourage the person from actively managing their illness. Also, a parent or caregiver may have issues of their own that gets in the way of their ability to actively, effectively support the treatment and management of the adolescent's illness. So a health psychologist can jump in and help here by developing the best ways to teach the complex treatment regimen to adolescents in a way that they can understand and in a way that they can effectively implement, and to the parents and caregivers. And teaching the parents and caregivers to find a happy medium between recognizing the legitimacy and the severity of this illness and not bubble wrapping the child. Additionally, they can help normalize the illness and combat stigma. Yes, this is legitimate. There are legitimate things that you're going to have to do that are different from people that don't have type 1 diabetes. And it doesn't mean, you can't still have a fulfilling life. And health psychologists can be really useful to help people proactively cope and problem solve. So the individual can adhere to their treatment regimen and still go out and do things. So, you can still go out for a dinner at Boston Pizza, but here's a plan. So you know what you can eat or you know what to do afterwards. So with that is the end of chapter 14. So we only have one chapter left, which is just kind of wrapping it all up and talking about what one does with health psych and where to go from here. So like I said, when I do that video, I'll chat a bit more about the final exam coming up. And by that point, your deadline will have passed for your second Healthy Change Journal. So I'll fill you in a bit more about when to expect those grades. But otherwise, work on that journal. Keep an eye on deadlines for the final quizzes in case any don't lie on a Friday. Because I'm going based off memory here, but I feel like 15 doesn't. But if I'm wrong, I'm just wrong. And otherwise, email me if you have any questions, but take care.